topics. I will try to be all-inclusive, but the talk today is going to focus on what you need to pass the board. So there's going to be some stuff that you're not going to hear me talk about because you don't see it on the in-training exams, and when I get some feedback, you don't hear these topics on the board. So the areas of focus on this lecture are for the boards. So you're not going to hear things like what porous coated stem is the best, what anticoagulation method is the best, because they're just too controversial. The areas that I'm going to get you through are the basic questions that I see over and over again. I've gone over all the in-training exam and self-assessment exams. And so since Mark only gives me a couple hours, I'm going to get going. Okay? So I'm going to first start on hip arthroplasty and hip-related subjects. Hip replacement surgery. Main goals of hip replacement are relief of pain, resumption of ADLs, and maintenance of independence. That was started in the modern era with John Charley in '71. The active patient presents a significant problem, and that's where we're going to talk about fixation and then the alternative bearing surfaces. The wear profile of the bearing is one main problem that causes osteolysis. And then another main issue that you're going to see is hip stability, where we have problems with dislocation. You're going to be hit with many questions about that. You'll say, hip replacement surgery, bone ingrowth, why? If you look at the cemented hip series in the United States, there's a high failure rate, as much as 2/3 at 15 years in young active patients. If you look at the European experience, it's pretty similar at 66% in the young active group. And if you look at the young active patient, what's the problem? The difference between an older patient and a younger patient is that they're generally more cycles, more stress on the implant surface, more stress on the bearing, more wear, and generally a weak cement mantle. In training question 05, the difference between a cemented hip and a young patient and an older patient, cycles and stress and osteolysis. The more you wear that bearing, the more osteolysis you're going to get. It's very analogous to driving on the freeway. This is the freeway I drive to work downtown LA. If you look at the fast lane, low frequency, low weight, low wear, the cement mantle is going to hold out fine. If you look at the slow lane, you have high frequency, big fat trucks, high weight, high wear. You're going to crack that cement and it's going to fail. And that is the bottom line with cement fixation in young active patients, both cup and stem. Remember that cement fixation is a mechanical fixation. It's a micro interlock into the bone. The cement will fatigue and microfracture. Once it fractures, there is no remodeling of that fracture. It also is one additional interface that can fail. So you have an interface between the prosthesis and the cement, and then you have an interface between the bone and the cement. And both of those two interfaces can fail. For the in-training and for the board, cemented cups fail at a higher rate than cemented stems, usually seen around 10, 11 years. The reason is that cups are at a theta angle, so there's a shear component, so they will have a shear and tension force, and they pull off an abduction and fall. Stems are usually in compression. Test question over and over. Cement resists compression better than tension. That's why stems last longer than cemented cups. Okay. In contrast, bone ingrowth is dynamic. You have a biologic fixation. There is ongoing bone remodeling. So if you do get a little micro crack somewhere in the system, it will remodel. So potentially, that interface is life-lasting. The success in design is design-dependent and technique-dependent, and we'll go over that. Depending on the amount of motion between the implant and the bone when you put it in, you can have bony ingrowth, which is desired. You can end up with fibrous ingrowth, which is not desired, or you can have a rotten result with fibrous encapsulation and settling and gross pain. The success requires these criteria be met. You have optimum pore size of the implant, optimum pore depth, optimum porosity, minimal gaps, rigid fixation. You want to minimize your implant micromotion so the bone will grow in. You want cortical contact, and you want normal bone metabolism. Remember that the bone's got to be alive for bone ingrowth to occur. If you have a radiated bone to the hip and pelvis, you have a higher risk of aseptic loosening. That makes sense. You want a prosthesis that's going to have the bone grow in, and it's dead. It's not going to work. Okay? If you look at the pore size, studies have been done to show the optimum pore size. Two classic studies have shown the pore size between 50 and 400 microns. Clemau is very similar in that range, and that's very important. Pore depth is important. The deeper you go, the better it gets. You get more interdigitation. You get a stronger bond, and that makes logical sense. If you look at this study by Cook, different pore sizes but different depths of the pores, 2 beads deep, 3 beads deep. In each one of those series, the deeper you go, the stronger the bond. The porosity is important too. You can't make your surface too porous. The area of porosity is needed for fixation, but if you make it too porous, then the entire porous coating will literally shear off your prosthesis. So the optimum porosity is 40 to 50%. And these are all mistakes that we made clinically back in the 80s, and we had a lot of learning by the hard knocks. If you look at the porosity by 4 different studies, if you increase the porosity, you increase the interface shear strength of that bond. The maximum porosity is around 55%. After that, it gets too porous, and you start seeing the shearing of the porous coating off of the metal, and it will happen. Roy Blebaum out in Salt Lake City did a great study showing that the gaps between the prosthesis and bone must be less than 50 microns. Also, if you want a porous coated implant to work, you've got to have implant micromotion that is just still. You can't have a moving target for the bone to grow in. Permissible displacements in a dog study showed that you had to keep the implant motion less than 28 microns for you to get good ingrowth all the way around. If you had motion greater than 150 microns, that was associated with fibrous ingrowth. That's why we put patients on crutches. That's why we try not to put patients full weight bearing right away, because you get a little bit of bending moments in that femur, you get some micromotion, the bone won't grow in. There are 2 ways to get your ingrowth. There's a press fit technique, which is the most common. There's another technique that you need to know. It's line-to-line technique. The press fit is a technique and not a fixation method. You don't want to say, I'll put in a press fit hip. Rather, you put in a hip with a press fit technique and you have biologic fixation. So in this case, you ream the canal to a certain size. You insert a stem that's slightly larger in that size. Similarly, with the cup, you ream it to a certain size and you insert a cup that's a little bit bigger and wedge it in. And so it's the concept of when you are chopping wood, you put a large peg in a small hole, you wedge it open, it creates compression hoop stresses, and those stresses around that implant hold it in place temporarily until the bone grows in. If you don't have the proper method for fixation, you don't have the correct porous coating, those hoop stresses will relax over time after about 4 to 6 weeks, and your stem will settle. So what you're betting on is during that time of your compression hoop stresses that the bone will grow into the prosthesis and remain stable. So your initial rigid fixation is the press fit. Your long-term fixation, though, is the biologic microinterdigitation of that bone into those pores. So the compressive hoop stresses just provides the initial stability. That's why it is a technique to provide the long-term fixation. Questions for the boards. The most common complication for press fit technique is fracture, right? Wedge something in that's tight. You do it too much, it's going to break. It is the main reason for acetabular fracture in total hips when you see acetabular fractures with non-cemented press fit cups. Usually what happens there is that the bone is relatively soft. You ream it, under-ream it, and then you just take a 5-pound mallet and bang it in, and you break the rim. So that's the most common reason for acetabular fracture. The other technique is line-to-line technique. Again, a technique. You ream the canal to a size. You insert a stem of the same diameter. So you ream 16 millimeters, you insert 16 millimeters. The difference here is that you have an extensive porous coating which provides an interference fit. It's a rough surface. That rough surface over a long surface area will hold it still. The long-term fixation is, again, biologic. Same thing with the cup. You ream the cup to the same size. You insert the cup of the same diameter. So you ream 56, you put in 56. Initial fixation relies on screws. A long-term fixation is biologic. The bone grows into the pores. It is a technique that's not as popular as press fit because you really rely on your screws. And if you don't have good screw fixation, your cup comes loose. So the press fit cup technique requires no screws. In contrast, a line-to-line cup technique requires and relies on screws. You die by the screws. If you don't have good fixation, it comes loose. Okay? Most people will do a press fit cup, and pants and suspenders will add 1 or 2 screws to help you along. Also remember that Kant-Cell's bone is not weight-bearing. The stem must be against cortex for fixation. And you think that's intuitive now, but back in the 80s when we were putting these stems in, we would put them into Kant-Cell's bone because we thought that it was, quote, more metabolically active, that you would get more ingrowth. But what would happen is that they would grow in okay, but with cyclic loading, they would actually settle. The Kant-Cell structure would fatigue and break. So what we want to, and Clemhouse showed that the shear and torsional strength is much stronger when the implant's adjacent to cortical bone as opposed to Kant-Cell's bone. So that's why newer designs are designed to fit against the cortex, so there is that extra stabilization. So in the old days, we'd put the stems in that Kant-Cell's bone, as you see on the left. What we do now is that we want cortical contact to provide that fixation. So putting it all together for the test, remember the best way that I put together for this is the mnemonic of the 50s. For bone ingrowth, you want cortical contact, you want your gaps less than 50, pores between 50 and 150, porosity not greater than 50, and micromotion less than 50. And that, if you see those numbers and you see a difference of different choices, if you remember the mnemonic, that gets you in the range. And they're not going to really test you real close numbers. They'll put numbers that are far out to the left and far out to the right. And if you can remember these numbers, that'll get you into the ballpark. Okay. Another form of fixation is bone on-growth. It's a surface process where you blast the metal with a grit surface, either with glass beads or hydroxyapatite. It creates micro divots, and the bone grows into those divots, and you get a surface apposition of bone. The peaks and valleys of the divots are similar in size to the opening seen in a porous-coated surface. The bone grows into those valleys, providing a micro-interdigitation. So this is an example. Here's your grit-blasted stem. The bone then grows into it and makes it stable. The surface roughness is important in grit blast fixation. The definition of surface roughness is the average peak to valley, and that's a good item to know. Studies show that there's a linear correlation between surface roughness and strength. So it's the surface roughness that determines the strength of your fixation in a grit-blasted construct. Okay? The success becomes much more dependent on geometry since you don't have a big porous coating surface that's rough and you don't have the geometric designs. You really got to wedge these in really tight. So grit-blasted stems tend to be really sharp tapers, and they have to have a real rigid, tight press fit. And the grit-blasted areas tend to be extensile all along the entire surface. As you would expect, if you wedge something in really tight and it's really sharp, you're going to have problems with fractures. And so grit-blasted stems, when you wedge them in, do have a higher rate of fracture risk. Again, the drawbacks of grit-blast fixation, it is on-growth only. It doesn't go deep. It's just on the surface. The technique is not as forgiving, so if you don't have that good press fit, it will settle, and you must wedge it in very, very tight. Going on to hydroxyapatite, this was seen in trainings in multiple times this year and previous. It is osteoconductive only, not osteoinductive. Here's the test question. It allows for more rapid closure of gaps. So what happens is that when you put these implants in, some of the osteoblasts like that surface. Osteoblasts stick to the hydroxyapatite surface, and then you have bidirectional closure of gaps. So the gaps close from both directions, as opposed to having a porous-coated surface and bone. The bone will grow into the porous coating with one direction. So the HA gives you a quicker closure of the gap. And that's the big advantage of hydroxyapatite. That was OITE 05. Successful application requires high crystallinity. Amorphous areas will dissolve. That's another test question. So your processing is very important. You need an extremely high crystallinity for long-term survival. The thickness is generally around 50, so you can add that to your rule of 50s. Thicker coatings will crack and shear off, so we want a 50-micron surface preferred. The surface roughness on the metal substrate helps in holding the HA in place. It gives it a little bit better interface fracture toughness. Remember this, that hydroxyapatite alone may delaminate in the long term, so if you want long-term success for the hydroxyapatite stem, hydroxyapatite on the porous surface is probably a safer choice. So if you have a smooth titanium stem and you put HA on it, the bone will grow onto the HA and you will get a good bond. However, if there are amorphous areas in the HA and it dissolves, the implant will settle off of the HA and come loose. So what you really want is you want those gaps to close quick, and then you want the bone to grow through the HA and into the porous coating. And that's the theoretical advantage of having HA, especially in revision implants. It helps that healing process quicker. Non-cemented implants, multiple permutations. The extent of coating, it can be proximal, proximal 2/3, extensive, hybrid. So there's proximal porous coating on the top, grid on the bottom. Technique, press fit, line to line. The metals are different. Titanium or cobalt chrome are usually the implants used. The designs are different in the bodies. There's tapers, straightened bows. The designs can either be round, square, hollow with splines. The surfaces can be grit, smooth, HA, hybrid. And this is the problem. There's no one stem that stands out. If you obey the techniques of press fit and get a good fixation, most implants will work well. So in terms of non-cemented hip fixation, there are too many stem permutations to make a blanket statement about the long-term effectiveness of non-cemented stem fixation, and you will not hear that on the test. What you will hear are what makes a non-cemented stem work, and those are the things that you want to hear about. On the other hand, you need to know this, that porous-coated hemisphere cups have a reliable long-term result. That it's a hemisphere is a hemisphere is a hemisphere. You put porous coating on it, it's going to work. So they will hit you on that, showing that porous-coated cups all have long-term ingrowth rates that are, and good long-term survivals. If you look at the gold standard, the NIH consensus statement recommended a hybrid total hip, which is an uncemented porous-coated cup and a cemented femoral stem. What you will see on the boards is in younger active patients, because of the higher cycles, the higher stress, and the higher wear rates, that they will probably advocate a porous-coated stem. And they're not going to say what design. So what they will tell you is that the standard fixation now for the acetabulum is definitely a porous-coated hemisphere cup. The stem, I don't think they're going to ask you because that's too controversial, but if they lean you in a direction, young active patient, high cycles, going to anticipate a long life, probably would lean towards a porous-coated implant. Okay. This is something you need to know about stem loading. Proximal porous-coated stems, the load is transferred from the stem to the bone. The load is transferred in the metaphysis and proximal diaphysis. If you look at this diagram here, the porous coating is up proximally. You load into the metadiaphyseal area, and the load is transferred proximally with preservation of bone loading. With extensive porous-coated stems, the load is transferred from the stem to the bone, but the load bypasses the proximal femur and actually comes out more distally, and that's been proven in many studies. And what you see is the distal spot weld, and I want you to remember that because that will be on the test. What happens is the load comes in proximally and exits distally, and on X-ray you will see the spot weld. And this is the classic spot weld with an AML stem. The load comes out distally. You will see that increased bone density, and they'll say, is that a problem with a fracture or is that hypertrophic growth? No, that is a classic spot weld of a porous, extensively porous-coated implant. So remember that and memorize it. Interestingly, if you look at cemented stems, the load is transferred from the stem to the cement and then to the bone. The load actually bypasses the proximal femur, and you actually see stress shielding. This is the cement mantle with loading. If you look at DEXA studies, cemented stems show a definite loss of bone density in the proximal area. So cemented stems actually stress shield as well. So just remember that point. Okay? Stress shielding, usually seen, is described as proximal bone loss over time in a well-fixed implant. It's usually associated with a large, stiff cobalt chrome stem with extensive porous coating. For the questions on the boards, stem stiffness is the main determinant. A big, stiff stem stress shields more than a smaller stem. The extent of the porous coating is not thought to be as important. The problem is a modulus mismatch between the stem and the bone. If you look at stiffness, and Chalber talked a lot about this a little bit, cobalt chrome is more stiff than titanium alloy, so you will see stress shielding more with cobalt chrome stems. Stem size is the most important. Stem stiffness is directly related to the area moment of inertia, as Bobby just talked about, so it's related to the fourth power of the radius. So a larger stem gives you a much exponentially stiffer stem. That's why if you add the metal of cobalt chrome along with a big diameter stem, you have a very stiff construct. That's where you're going to see your stress shielding. So more stiff stems tend to be solid. They tend to be big round stems with a large area moment of inertia. If you want to decrease your stem stiffness, you hollow it, you slot it, you taper it down, and you flute it. That's why with the more third-generation designs, you see more titanium stems. You see more tapered stems. You see slots because you see this stress shielding. And stress shielding is related to stiffness mismatch. Cement technique. First generation, this is a personal interview with Bill Harris himself. They don't ask these questions as much anymore, but it's good for historical significance to know the difference between first, second, and third generations. First generation, you finger pack it, no preparation. You just put the cement in, plugged it in, and put it down. Second generation, they used an injection gun, washed out the canal of the blood, prepped the canal, dried it out, packed it, used a cement restrictor, used a little bit stronger biomaterial for the stem, and used a collar. Third generation is the big difference here where you have porosity reduction. You use a vacuum or use a centrifuge to reduce the porosity in the cement. You pressurize it. Use a thumb or you use a pressurization technique to really squeeze that cement into the interstices of the bone. Use a pre-coated stem. That's tending to fall out of favor. A little bit of a rough surface to hold it, to bind the cement to the prosthesis. And use a centralizer so you don't have a mantle defect. Remember this for the boards. A mantle defect is the only area in a cemented stem that's been associated with higher loosening rates. So a mantle defect is a place in the construct where the prosthesis touches the bone. It is an area of concentrated stress. It is associated with higher loosening rates. This is a mantle defect. I will predict that this stem will come loose at 8 to 10 years because that is an area of concentrated stress. You will see cracking of the cement. You will see a localized osteolysis in that area, and that stem will come loose. That is the only predictor of post-operative radiographs that can predict loosening. Okay. Stem breakage, failure mode, cantilever bending. Got to remember that. You load on the head, and you have a cantilever bend. The stem is actually fixed distally, and then you cantilever bend. So you pot it distally, it bends up here on the top. It's seen more with cemented stems because they are generally smaller and will fatigue earlier. However, small AML stems will cantilever bend and break as well. As you can see, that AML on the right there is a small stem that broke in the same method, cantilever bending. Okay. Anatomy question, sciatic nerve. Comes closest to the acetabulum at the level of the ischium, been on the in-training, has been on the boards. It is the most common reason for a sciatic nerve palsy is errant retractor replacement posteriorly. You lever on the nerve. If you lever on the nerve, which part of the sciatic nerve do you hit first? Anybody? In-training board question. Perineal portion of it. You usually end up with a foot drop. In DDH, you run the risk of nerve palsy as well with lengthening over 3.5 centimeters. So in this picture here, you can see the ischium. This is a recurrent dislocator that I've revised. You can see the sciatic nerve autodissected right next to the ischium. And you put your retractors there. That's where you're going to get your levering, and you're going to squish the nerve. Okay. Medial femoral circumflex artery. This picture is a left total hip. The acetabulum is up there over to the right. The gluteus maximus tendon has been released off the femur and pulled back. That arrow shows the medial femoral circumflex artery. So it tends to be right underneath the G-max tendon or at the border, inferior border of the quadratus. If you take your bovie and go straight down rather than in at an angle, you will cut it and you'll get a big area of bleeding. You pack it off and you start to panic. Don't panic, just cauterize it. You're not going to have any major damage. Okay, but that's the artery that you hit. Another good question that they'll ask here is a right acetabulum. There's a transverse acetabular ligament. Just below there, if you put a retractor there, is the obturator foramen, and this is where you can, if you're too aggressive, can damage the obturator vessels in this area. And again, if you get a bleeder in this area, you pack it off and cauterize it and you'll be okay. So you've got to be careful in this area. Complications with total hip: sickle cell, knee-jerk response, early loosening. Sickle cell, you have regional bone necrosis. Excuse me on that, I'll come back here. Sickle cell, you have early loosening. Psoriatic arthritis, you have these open lesions over your area of operation, and you get infections because these psoriatic areas will split open and you'll allow bacteria into the wound. So you have a higher rate of infection. Ankylosing spondylitis is associated with heterotopic ossification. Those are all three knee jerks. Complications you've seen before: hip hematomas from anticoagulation can cause sciatic nerve injuries, and if they do not resolve quickly, one should consider exploration to evacuate the hematoma. Parkinson's disease are associated with much higher medical comorbidities and orthopedic problems. There is a higher dislocation rate. There are higher periop mortalities, higher medical complications, and a higher reoperation rate. This is a gentleman that I did, Parkinson's disease, hip fracture with a hip arthroplasty. Came back 4 weeks later with these massive decubitides over the back and over the hip, hips resected with a vastus lateralis flap. Venous thrombosis, they're not going to ask you questions which anticoagulation is the best, but they will ask you about what happens during hip replacement and knee replacement. And you have an activation of the clotting cascade, and it occurs in the hip during surgery. So the greatest risk of activation of the clotting cascade occurs during the insertion of the femoral component, whether it be cemented or uncemented implants. The risk factors for thrombogenesis are venous occlusion during preparation and insertion of the femoral component. So if your hip is flexed and turned around 90 degrees and you're torquing on your vessels, this is where you're going to get your venous occlusion. Okay? Also, use of cemented femoral stems, get a lot of fat shed, you activate a lot of clotting factors, you're going to see a higher risk of venous thrombogenesis. Nerve palsy, sciatic nerve is the most common nerve involved in hip replacement. Perineal nerve division is most often involved because it's closer to the acetabulum and anatomically. There's a higher risk of sciatic nerve injury with female patients, DDH, and revision surgery. Fat embolized syndrome, seen with femoral stem insertion. This is actually a picture of a knee, but it's the best picture if you can see the fat oozing out of that bone with the cement. The hallmark is hypotension and hypoxia. It starts soon after your insertion or components, usually seen 30 to 40 minutes later. And your treatment is hydration and maintaining cardiovascular status. Approach questions: Harding approach, direct lateral approach. You come straight lateral, but you release part of the abductor sleeve anteriorly, and you dislocate the hip anteriorly. Once you approach through that gluteus medius muscle and you have scar tissue, you can result in some dysfunction and scarring, and you see more lurches in this approach. You've got to limit your external rotation and extension because when you dislocate anteriorly, this is where you do your releases. So a patient that turns out in bed, that's going to dislocate anteriorly. Posterolateral approach is in contrast. If you're approaching through the back, if you flex your hip, adduct it and turn it in, you're going to come out the back. So you want to limit flexion, adduction, and internal rotation. Osteolysis. My problem still with my patients, it's a histiocytic response to wear debris. You will be asked this on the boards. This will be the classic x-ray that you must memorize for the boards. It is bone scalloping around the stem. It looks like an infection, but it is not because it's got these round scalloping areas. Osteomyelitis usually is a pervasive erosion of the bone, but these round scalloping areas are the hallmark of osteolysis. It is seen with non-cemented and cemented constructs. Polyethylene debris is the main culprit in the traditional hip bearing construct. It is a bearing wear problem. The types of wear as described by Harry McKellop, he won the Charnley Award for this, is abrasive wear where you scratch some of the polyethylene off, adhesive wear, which is the most important reason for causing osteolysis. And then there's third body particles, which can get in the system and cause scratching. But adhesive wear is the most important. These are the wear sources. You can have a ball and cup bearing, which creates metal debris and polyethylene debris. The cement and stem interface can cause debris, as well as cement bone interface. The point here is that all these areas generate debris. The debris gets phagocytized. The macrophage becomes activated. The macrophage is the target cell in osteolysis. Remember that. And that sets off the osteolytic reaction. You're not going to know the exact process with the osteolytic reaction, but at the primary articulation, it is a submicron shedding of polyethylene particles generating as a result of adhesive wear, which generates billions and billions of particles. And here is the classic example. I got this from Harry McKillop. Scanning electron micrograph of an acetabular cup. And so on the left, you have these little tiny beads in the cup. And if you look at and put this in a wear simulator for 10 million cycles, and you look at the debris on the bottom of that, you see these little beads at the bottom of the wear simulator. And if you look more closely, what you see at these arrows are these little stretched areas of polyethylene. So what's happening is that when you're having this cycle, your ball is going through a cycle, it is literally pulling off these beads, bead by bead. And they are submicron beads. And it just so happens it's the submicron beads that get into the macrophage that cause the reaction. It tickles them, and then they become activated. Large chunks don't get imbibed into the macrophage. Only these small submicron pieces. So you have phagocytosis, submicron particles, mainly polyethylene. Could do metal, but polyethylene by far is the softer part and generates the most debris. You get macrophage recruitment and release of osteolytic factors. These include interleukin-1, tissue necrosis factor alpha, that's a test question, oxide radicals, hydrogen peroxide, prostaglandins, primary Ig1 and E2, and acid phosphatase. And why is acid phosphatase important? Because it dissolves bone. So you have the activated macrophage and it releases acid phosphatase and dissolves that bone. In the joint, you have the polyethylene debris being generated. You get a hydrostatic buildup of pressure because you have particles in there. It's like a swollen eye. You get all this inflammation. And then that pressure disseminates those particles around the effective joint space. And this is another important question for the boards. This is like Parsons picks. This is it right here. The effective joint space is defined by Schmalzried. He won the Charnley Award for this, is that it is the effective joint space is not just a joint, but it's anywhere where the prosthesis touches bone, anywhere in that system. So that red area is the effective joint space. So if you have a screw all the way up in the pelvis, that screw is the area of the effective joint space. And so that debris can be pumped behind the cup, around the screws, around the stem distally. And where does it go? It goes through mechanics. It's the path of least resistance. So you have an area that's easier to pump down into the stem, you're going to get osteolysis in the stem. If you've got your stem well sealed off with extensive porous coating, then the osteolysis is going to go around the cup. If you have a hole in your cup behind your polyethylene, it's going to go through the hole, and you're going to get a blowhole phenomenon. You're going to get an osteolytic lesion behind the cup around one of those holes. So remember, fluid moves in the path of least resistance. It will go around the smooth areas, including the screw holes. So if you have a fully porous coated stem, this is a board question right here, you will see lysis mainly at the greater trochanter and not along the stem. And you will have a fracture at the greater trochanter because of your osteolysis. If you have a proximal porous coated stem that just has a couple patches and the osteolysis goes around the smooth areas, you're going to get lysis at the stem tip. It's just basic hydrodynamics. You just pump it where it can go. And just remember that. Another great question will be on the boards. If you have lytical lesions around the screws and your cup is fixed, the answer is don't take out the cup because you'll have these huge holes and you'll require a cage. What you do instead, change the modular cup and bone graft either through the screw holes or a little trap door up in the ilium. And that's a little favorite question that I've seen over and over. That was OITE2, and also 4 and 5. Osteolysis, the particles generated are a result of activity level. So if you have a younger active patient, you're going to have more osteolysis, and that was on the in training last year. Implant design. If you have a cup that has backside wear of the polyethylene against the metal, you're going to have more particles generated. If you have a rough head, you're going to get more generated particles. The bearing material, either metal poly or ceramic poly, if you have a rough head on that, that may cause more osteolysis. Implant fixation, if you have a little bit of micromotion, you generate some particles that cause abrasive wear, you can get it. Surgical technique leaves third body particles. And remember this, polyethylene processing, compression molding is the best in resisting osteolysis. In fact, direct compression molding is the board answer, and I'll show that in the bearing lecture. The osteolysis threshold it's interesting. It relates to the concentration of the particles in the affected joint space and the biomaterial reactivity. All debris generates reactive material, including cobalt, chrome, titanium, and polyethylene. But polyethylene has so many more particles than the others that this is the main cause of the osteolysis. You can have a certain level of particles in the system, and some patients will get osteolysis and some won't. And that has to relate to the individual body response to inflammatory particles. That's why some people don't get as much osteolysis. And also, there is a clearance rate. Some people will, through the lymphatic system, clear out those particles better than others. So if you have a good lymphatic drainage system, you can see polyethylene debris in your blood and local regional nodes up in your abdomen. Those patients get less osteolysis. Okay? So those are the factors of why some people, you'll see a pristine cup, you'll see eccentric wear but no osteolysis. Why? Because of all those variables right there. Okay. Abrasive wear. Avoid titanium heads. They tend to scratch easy. Remember this, do not cement titanium stems. Titanium stems with the lower modulus tend to move a little bit with the cement mantle and generate titanium debris, and they generate a significant amount of third body particles. Okay. With the traditional bearing, hard on soft, metal on polyethylene, volumetric wear determines the amount of particles generated for osteolysis. So on the left side, you have a ball in a cup, and you wear through that polyethylene cup. W there is the linear wear rate. When you wear into a cup, you actually are wearing through a cylinder, and the formula for that cylinder is volume is pi r squared times the linear wear rate, which is W. The point here is that volumetric wear is directly related to the radius of the head squared. A larger head generates more polyethylene debris, which equates into more potential for osteolysis. Okay? So it's the square of the radius. So if you look at the traditional total hip, before we came with these alternative bearings, we had the Charnley style where you had a 22 millimeter head, and then we had the larger 32 millimeter balls. With a small ball, you have a higher linear wear because you have a higher pressure moment or contact stress, so that you have a 22 millimeter head wears faster through there. However, you have a lower volumetric wear. In contrast, a larger head, you have a low linear wear, but because of its large radius, you have a higher volumetric wear, so you have more problems with osteolysis. Therefore, with the selection of head size with the traditional hard-on-soft bearing, high linear wears, the prostheses will fail by wear-through, i.e. Charnleys will wear through their plastic. Volumetric wear, if you have a large ball, you'll have high volumetric wear and the prostheses will fail by osteolysis. Hence, the practical solution has been the 28 millimeter ball, which is the best compromise, so it has less volumetric wear than 32, less linear wear than the 22, and better hip stability than the 22. And 5 years ago, that was plain and simple, but now we have all these alternative bearings. So that was the logic of how we came to 28 millimeter balls in hip replacement. The Gruen zones describe radiolucencies. Just remember this for the boards, that the hips load with cantilever bending, and if you have a cemented stem, you're going to see your radiolucent line first in zone 1. That's why Tom Gruen labeled that area zone 1, because that's where the action is. Because you're going to cantilever bend, and if the stem's going to loosen first, you're going to see it in zone 1. Okay? The Lee and Charnley zones are 1, 2, and 3. You're going to usually see your radiolucent lines more in zone 3 because you're going to have shear and abduction pull-off, so you'll tend to see your radiolucent lines more inferiorly. Okay. Osteonecrosis. The final common pathway is intravascular coagulation. In this process, you have an interosseous microcirculation coagulation, generalized venous thrombosis, and a retrograde arterial occlusion. This intravascular coagulation is always triggered by some underlying etiologic risk factor, hypercoagulable sites, alcoholism, dysbaric disorders like deep sea diving, hemoglobinopathy, sickle cell, sickle thalassemia, hypercortisonism, including anabolic steroids, malignancy, radiation therapy, pregnancy, and trauma. Risk factors also include antiphospholipid antibody syndrome, hyperlipidemia disorders, hypersensitivity reactions, i.e. allergic reactions. Remember also viral. HIV itself can cause AVN. Guy Pimon out of UCSF has described that. Protease inhibitors also cause AVN. The more traditional test questions that you'll see, risk factors for osteonecrosis, generally protein S, protein C, and anti-thrombin deficiency. You see that a lot. Lupus anticoagulate has also been one that you see on the tests. Lipoprotein small a excess and homocystinuria are also ones that you'll see in the test. Homocystinuria, what's the treatment there? Folic acid. If you take folic acid, what happens to you? You get flushed in the face. I've tried it. I don't like it. Osteonecrosis activation or osteonecrosis classification no longer is FECOT. They throw in now the MRI. And they're not going to ask you about the numbers for the staging system. What they're going to ask you about is the crescent. Stage 3 is, in whatever system you use, is where you have subchondral collapse. The subchondral bone is resorbed away from that cortical rim, and you have a potential area for collapse. So the bone underneath is necrotic and is collapsing underneath the cartilage. It is a poor prognostic sign. When present, a core decompression won't work because you've already had the collapse. Here's one. You look at this hip x-ray, you say, this is AVN, this doesn't look too bad. This is the head. This is what that head looks like with that x-ray. Okay? So if you see a crescent sign, you know that bad stuff's already happening. That's why treatments don't work very well after you see the crescent. So stage 4, you have flattening. Stage 5, there are acetabular changes. And 6 is advanced degenerative arthritis. But don't remember all that. Remember the concept. Stage 0, everything's negative. MRI, everything. Stage 6, everything's arthritic. And in the middle, you have the crescent sign. And that's what you really need to know. If you look at the staging system using volume percents, what they'll do is they'll add the percent involvement on AP and lateral. So if you have 50% head involvement AP, and 50% head involvement on the lateral, 50% times 50% equals a quarter, or 20%, and that's why you have these lower levels. So A is 15 volume percent, B is 15 to 30 volume percent, and C is 30, and that's pretty big head involvement. The size of the necrotic lesion most strongly influences the risk of head collapse. That's the board question. Okay. Treatment options for osteonecrosis: core decompression, fibular strut, vascularized, osteotomy, hip replacement. Now, core decompression, the rationale here is that with osteonecrosis, you have interosseous hypertension evident at all stages, as found out by Hungerford in his tests. Bone is actually a Starling resistor. What is a Starling resistor? It's a hard shell that, when pressurized, can expand. So anything that's inside will get compressed. So you have a hypertension present, you will compress the vessels, and then you will get decreased flow. So if you have this ongoing ischemia and you put weight on this ischemic bone, it will collapse. The idea of a core decompression is to create a wound which stimulates healing. So if you drill a hole, you decompress the hypertension, so you get pain relief, and then the hole, because you have activated the system like breaking a bone, is going to start healing. So the principle here is you get reduction of the hypertension, which immediately relieves your pain, and then you get adjacent creeping substitution, which heals the necrotic area. The indications: you can't have subchondral collapse. If the head has already collapsed down, it's not going to push itself back up. If you have patients who have avascular necrosis on steroids, core decompressions, have a higher failure rate and don't work. So if I have somebody with AVN on long-term steroids and they're not going to get off of it, such, for example, a rheumatoid, I don't do a core, and neither should you. It is a meticulous technique. You've got to get the core all the way up to the subchondral plate. The difference now with a vascularized fibular strut is you make a large hole for insertion of the mechanical strut, but also remember this, you take out the entire necrotic lesion. So if it's not a core hole and a strut, what you're doing is getting out all of that necrotic bone. And then the vascularized strut is in there to keep the subchondral plate from collapsing down, and you put bone graft around that to heal everything. So the core and the strut stimulate neogenesis. So in this case, here's AVN in a young patient. There's a big core, there's a burr getting out the rest of that necrotic segment, and then the strut goes in, and then there is bone graft around all those areas. So you're literally performing a surgical extirpation of the necrotic bone and putting fresh cancellous bone in there. The strut keeps things from collapsing. My best interpretation for vascularized fibular struts is young patients who shouldn't get hip replacements. We're talking the 20-year-olds. We're talking the 30-year-olds. It's usually used in large necrotic segments. Remember I told you the risk of collapse is directly related to how big the necrotic lesion is. So if you have more than 50% head involvement on one plane, you have a higher risk of collapse. That's the indication for a fibular strut in my mind, and I've talked with others. So young active patients that shouldn't get hip replacements, no crescent sign, and a large area of involvement. Patients with osteonecrosis or degenerative arthritis, the most appropriate treatment, even in younger patients, is total hip replacement. That was a in-training question. If you have arthritis, you should resurface both areas. Going on to periprosthetic fractures, there will always be a question on the boards with this. Remember this, if the stem is loose, you've got to revise the stem and fix the fracture. You fix the stem with extensive porous coating, and that's usually the preferred choice. You use allograft struts or cables around the break. A corollary question on OITE 5 this year is they showed a periprosthetic fracture, loose stem and loose cup. If this cup is loose too, you've got to revise the cup too. So anything that's loose, you revise and fix the fracture. So here's this case, a broken stem, periprosthetic fracture, everything's loose, you've got to revise the whole system. Okay. Now, if the stem is stable, and it's just around the greater trochanter, you usually treat those non-operatively. If it involves the proximal metadiaphyseal flare around the lesser trochanter in that area, you try to treat that non-operatively. And if you want to fix it, you can, but they won't ask that question because there's no one definitive answer. Now, this is where you need to pay careful attention. If you have a stem that is stable and involves the stem tip and less than 25% of the prosthesis, and it's cemented or non-cemented, you have multiple choices. You can revise it with a long stem. You can treat it with plates and screws and plates and struts and cables. The choice depends on which construct provides the maximum stability for healing but doesn't compromise the fixation. So there's no one definitive answer. This is the test question. If it's a stem tip and it's greater than 25% of the prosthesis and it's cemented, you have lost the fixation of your cemented stem, and you must revise the stem. And this is a straightforward question. Okay? The other ones have too many answers. There's no one correct answer, but this one is right here. Okay. Now, if it's greater than 25% of the prosthesis and it's non-cemented, too many variables, because if it's a proximal porous coated stem and you've fractured and it's more than 25%, you still may be able to put that together. On the other hand, if it's an AML stem distally where you get most of your fixation, you've got to revise that. Too many variables here. You're not going to get that. So the ones that you're going to get for the test, if the stem is loose, you've got to revise and fix. If it's a cemented stem and it's more than 25%, you've got to fix it. And that was on OIT 5 this year and 4 and 3. Okay. Periprosthetic fractures, supracollar at the tip of a revision stem. Try to treat those non-operatively with a fracture brace. I just had one of those 2 weeks ago. You can use an ORF with plate and screws. You got those new plates that can go over the lateral femoral condyle and come up around and put cable plates on them. You can use a custom rod through the knee, but that's a rare situation. If you have a supracolumnar fracture distant to the stem tip, so you have a primary hip up here and a fracture way down here, you just treat it like a supracolumnar femur fracture. ORF with a plate is the #1 choice. Okay. Another big pick, acetabular screw placement. This is Wazlewski's work. Recognize a safe zone, no screws through the medial wall. Here's the thing you need to know is that the anterior superior area is the zone of death. And the way you draw these lines is you see line A where it is the ASIS, which is right there, right in that area right there. You draw from the ASIS and you go to the ischium, and that's your first line. And you draw a line perpendicular to that. If you just remember that the line starts with the ASIS, the zone just anterior to that is the anterior superior. AS, anterior superior. Anterior superior zone is the area where you can get the external iliac artery and veins. If you put screws there, you'll kill a patient quickly. And the corollary question is that you're putting your acetabular cup in, you drill a hole in your cup in the anterior area, and you get pulsatile bleeding. What do? You pack off the wound and you flip them over real quick because you don't have much time. Okay? The safe zone is posterior superior, which is up there in the ilium. And that's the place where you should put your screws. If you go posterior inferior, you run the risk of the sciatic nerve. And anterior inferior, you run the risk of the obturator nerve and artery. Remember that anatomy question, be careful with inferior retractors. That's where you get your obturator artery and nerve. So anterior superior is a zone of death. That is what they're going to ask you about. Or they may ask you the corollary, what is the safe zone? It's posterior superior. Just remember your line. ASIS to the ischium. Anterior superior is the zone of death. Loose total hip clinical presentation. Startup pain is the first and most common presentation. If your pain when you get out of a chair is in your thigh, it's usually a loose stem. If you get out of a chair and twist and it's in your groin, it's a loose acetabular cup. And the reason you get pain with sit to stand is because those are high joint reaction forces. That's when you're going to get most torque on your implants. Okay. Revision total hip, looking at bone defects. You can have segmental loss, which is either defined as loss of rim, loss of column, or loss of the medial wall. Cavitary means you have loss of cancellous bone, but you still have the main support structure, so it's little holes in the cancellous bone that can be combined. Here's an example of a cavitary deficiency. The rim is intact. These are little holes in the cancellous bone from osteolysis, and those are easily bone grafted. Here's cavitary deficiencies and segmental deficiencies. So the cavitary deficiencies are here. These are segmental deficiencies. So you've lost your rim and you've lost the medial wall. Those are segmental deficiencies. The rule is for revision hip surgery, if the rim is intact, you tend to use a porous-coated hemisphere cup with screws. You can accept 2/3 of a rim for a rim fit. So if you have at least 2/3 of a rim, you can still press fit a cup reasonably with screws placed in the posterior superior safe zone for your fixation. Areas of cavitary deficiency are filled with particulate grafts. Non-cemented porous-coated hemisphere cups are the preferred choice in this situation, not cement. If you are rim intact, you fill the cavitary defects with particulate bone graft. If you have a protrusio deformity, you can put a protrusio cup, so it's a hemisphere plus a cylinder, so it's a DP plus 5 cup. So you can put it in deep and get a rim fit and use screws. That's another way to get out of a deep hole. And it's not unreasonable to ream through the medial wall a little bit to deepen your cup so you can get a rim fit. If you are rim deficient, more than 2/3, then you need some type of cage support with the underlying bone graft. It's usually particulate graft, but if you want to use a bulk support allograft, a bulk support allograft is defined as a large chunk of bone, not particulate debris. So it's a femoral head or distal femoral condyle. If you are rim deficient, a bulk support allograft without a cage will have a high failure rate, and that's been shown. So if you put a big femoral condyle in and bolt it in and you cement into that, that bone graft will resorb and become loose and fail. So what we usually do now is we put the reconstruction cages in there and then put particulate graft and then use cement into the cage. So the cage load shares the forces through the iliac wing into the ischium, allows the particulate graft to heal without too much stress. Okay? So this situation here, left hip, massive osteolysis, protrusio deformity. This was treated with a reconstruction cage and particulate bone graft and a revision stem. On the femoral side, segmental bone losses are usually loss of the cortical tube with holes or loss of the entire proximal femur. Cavitary deficiencies are ectasia, which are dilatations from osteolysis or a combined defect. If the tube is intact and there's no significant segmental loss, the preferred answer is a non-cemented revision stem with extensive porous coating, and that's the most common solution. We try to run an extensive porous coating over and get the maximum contact area for bone ingrowth, because there are some areas that you will not get the ingrowth. Another board question: if you have a revision situation and you're revising a stem, you must bypass the distal defect by at least a minimum of 2 cortical diameters, otherwise you run the risk of fracture. So if you have a hole in your bone, you've got to pass at least 2 cortical widths below that. Okay? Otherwise you run the risk of fracture. Board question right there, okay? In revision femur, if the tube is intact and there's no segmental loss, you can use an impact grafting technique. That's why you have a big capacious canal, and what you use is you put allograft bone inside the canal and you cement and impact that you impact the bone against the wall, and then you cement in the stem. And if you have any deficiencies, you can use cerclage cables and wires for the weak cortical bone. And what you do is you cement this polished tapered stem into the particular allograft, which is basically dead bone, and the allograft is supposed to heal to the endosteal bone, which happens a lot, but not always, and the cemented stem stays bonded to the allograft. It's a little bit of a leap of faith, but it does work. The most common complication, as you would expect, if you put dead bone into the system and it doesn't heal, it's going to subside. It is a very technically and time-consuming procedure. You can't rush into it, so you've got to make sure that you have very tight packing of the allograft bone. It's not that commonly used stateside. You won't hear many questions about it, but the most common reason for failure is settling. I've seen that on the test questions. Okay. If you have segmental deficiencies, a non-cemented stem with extensive porous coating is still used. Allograft struts with cables and wires are used for the cortical deficiencies. Here's a situation: big hole in your bone from osteolysis. You put a stem that goes well below that, and then you use allograft struts with multifilament cables to fill those defects. Now, if the entire proximal femur is gone, you can use a bulk support allograft, and what you'll use is a cemented stem into the allograft. You step cut the allograft to the native femur, so you don't put a tube on top of the tube. You want a step cut so you increase the rotational stability. So you cement into the dead bone, you put the step cut, and then you cable those two together, either with or without a strut. And then you can either cement into this construct distally or use extensive porous coating. If you're using a porous coated prosthesis, you still use cement in the proximal portion and use the porous coating distally. Okay? And if the bone is gone and you want to use metal, you can use a big calcar replacing stem, and that's an acceptable choice as well. Young's modulus is always seen. I don't know if Bobby covered this, but in terms of the hip replacement and joint guys, ceramics the hardest, cobalt chrome's next, stainless steel, then titanium. Where they're going to get you on the test questions is the areas between cortical bone and cancellous bone. Just remember that polyethylene and cement live between cortical and cancellous bone. And just remember that cement can scratch polyethylene, so cement is always above polyethylene. And then you have tendon and ligament and cartilage, which I don't see anymore. I just put metal in it. So the test question usually has cortical bone, cement, methyl methacrylate, and cancellous bone somewhere in that system. Okay? Coefficient of friction, articular cartilage is the lowest. Ceramic on ceramic is next. Cobalt chrome, metal metal, cobalt chrome, then metal poly, ice on ice, steel on steel. So I'll get out of this one and go to the next. Okay, bearing lecture. We're talking about prosthetic articular bearings mainly for the hip, but they apply for the knee and the shoulder. Bearing couples in prosthetic joint replacement, the traditional bearing has been hard on soft, which is metal polyethylene or ceramic on polyethylene. There are the newer bearings, which are hard on hard, which are the metal metal and ceramic ceramics. And you're just now starting to see test questions on the in-training and on the boards on this. On a hard on soft bearing in the hip, the lubrication regime is boundary lubrication. Just remember that. In boundary lubrication, the asperities on each surface make contact always. They are never completely separated, and that is the definition of boundary lubrication. The fluid, in this situation, synovial fluid, separates the surface just enough to prevent severe wear, but they are always in contact. That's why you have adhesive wear and abrasive wear. The metal polyethylene construct, cobalt chrome on polyethylene, tends to be the best. Stainless steel on polyethylene is not used very much except in small patches in Europe. It is mainly historical. And titanium on polyethylene do not use. That is a bad bearing construct. You will hear that on the questions or on the boards. Here's the situation. A titanium head should not be used. It is much more softer and is much more susceptible to scratching on the surface and causes rapid polyethylene failure as a result of debris formation and osteolysis. In the cobalt or ceramic hard on polyethylene bearing, so if you use either a ceramic head or a metal head on a polyethylene bearing, optimum wear is related to surface roughness. So you have and that makes sense. If you have a rough head, you're going to scratch the polyethylene more, right? So in terms of cobalt chrome, it's the carbide asperities that stick out that cause the roughness and cause the scratching. And on ceramic heads, it is the residual pits in the manufacturing process that create the roughness and cause the scratching. Also, optimal wear is related to sphericity. So if you're out of round, you have high stress points causing increased wear on the polyethylene. Polyethylene osteolysis is generally a wear problem. The factors that affect polyethylene wear are the manufacturing of the polyethylene, the sterilization of the polyethylene, and the shelf life. All three are critically important. There are several manufacturing options. You can do ram bar extrusion with machining, sheet compression molding with machining. So you take these sheets and then mold it in. This is ram bar extrusion, so you put some polyethylene in, you take this bar and you push it out the other side, and it creates those big bars. The other option is compression molding with machining, so you take the polyethylene and compress it together rather than through a ram bar. And then finally, there's direct compression molding right into the implant. So in a direct compression molding, you take the polyethylene into the mold, you heat it, you press it, you have your implant. No machining, no anything. And the studies have shown that direct compression molding has the best wear properties of all the machining techniques. And remember that for the boards, direct compression molding. Okay. So better wear is consistently achieved with direct compression molding process, knees and hips and shoulders. Okay. In the process of manufacturing polyethylene, some techniques use calcium stearate. And the reason they use calcium stearate is because the calcium stearate wouldn't let the polyethylene bead stick to the mold. That was the only reason they used it. But they got into the polyethylene, created these beads, and caused fusion defects, which weakens the polyethylene and decreases the mechanical properties. And these were areas where you would see a lot of fatigue, fracture, and wear. So you don't want plastic with calcium stearate. So now all plastics are generally made without any calcium stearate. Now going on to sterilization, this is a process that has really evolved in the last 5 to 7 years. You can sterilize plastic different ways. You can use gas plasma with peroxide. You can use ethylene oxide, or low-dose irradiation. Low-dose irradiation is the most common. High-dose irradiation not only sterilizes but also processes the plastic to make it stronger. It has been used to improve bearing wear and improve the resistance for osteolysis. The key point that you need to know for the boards is that irradiation sterilization of polyethylene in air is bad. And that's what causes the major issues of polyethylene debris formation. So if you take some polyethylene, you irradiate it with 2.5 millirads, which is low dose. You generate free radicals as an intermediate step. And the pathway after that is you can either get chain scission or cross-linking. And cross-linking is desirable because that increases the properties of the polyethylene, where chain scission causes oxidation. So if you have polyethylene generating free radicals and you store this area, you store your polyethylene in oxygen, then you go towards the oxidation and you get carboxyl groups, chain scission, and weakened mechanical properties. On the other hand, if you store your polyethylene without oxygen, either in argon vacuum packaging or nitrogen packaging, you're going to get cross-linking. The main problem with oxidation of polyethylene is that it greatly reduces the mechanical properties of polyethylene, significantly. So when you cross-link polyethylene, you improve the resistance to adhesive and abrasive wear. So remember that adhesive wear problem with osteolysis? If you cross-link it, you have less adhesive wear. And you have improved wear rates both in simulator and wear data. Okay? So our current status with cross-linking of polyethylene is you can use ethylene oxide or gas plasma sterilization, which has no cross-linking, i.e. no effect on the polyethylene whatsoever. You can use low-dose irradiation in an inert environment, i.e. no oxygen when you get cross-linking. Or you can do high-dose irradiation in an inert environment, which gives you highly cross-linked polyethylene, which also improves wear resistance even more. So with ethylene oxide and gas plasma, you get no significant effect on cross-linking. If you take that polyethylene and compare it to low-dose irradiation, the same implant, same devices, same manufacturing, and use gas plasma and you irradiate, you will generally get higher wear rates on the gas plasma or ethylene oxide implants compared to the cross-linked. Okay. Now going on to high-dose irradiation, highly cross-linked polyethylene. Since we found that low-dose irradiation cross-links and you get better wear, i.e. less particles, less osteolysis, well, we'll just do more of it. And you get better wear rates with low dose. With low dose, you get better wear rates, so high dose is better. So what you want to remember, though, is that with high-dose irradiation, the mechanical properties are diminished. So even though you irradiate at high doses, you still got to take into the fact that low doses or high doses do decrease the mechanical properties. In high-dose irradiation, high cross-link polyethylene, there are 4 different methods. They are not equivalent. Each process is proprietary, and the goals with these post-processing radiation is to decrease the amount of free radicals. Remember, the free radicals causing oxidation. You want to improve the oxidation resistance, and you want to minimize the adverse effects by secondary processing, i.e. you don't want to ruin the mechanical properties. In polyethylene, you have 2 areas, crystalline areas and amorphous areas. The amorphous areas are the areas that cross-link, and the crystalline areas do not cross-link at all, okay? If you have a highly crystalline polyethylene, those are associated with a higher failure. And the reason is, the higher the crystallinity, the less amorphous areas, the less areas of cross-linking. So these areas are subjected to significant oxidation when exposed to oxygen. So if you have a highly crystalline product, such for example the Hylamer experience, which had a high failure rate, and you oxidize it, those amorphous areas will oxidize, and you have small areas, and they will just fall apart. So what you want to do with these post-processing areas of high cross-link polyethylene is low crystallinity, high cross-link. So the way that you improve your high cross-link product is these secondary processes. One is to remelt it. So you put this high-dose irradiation, you remelt it above 145 degrees, or you can heat anneal it, which heats below the melt point. If you remelt the polyethylene, so here you take your polyethylene, high dose of radiation, and you remelt it, what that does is the remelting process gets rid of the free radicals, and because the free radicals are out of the system, you can cross-link. And also the cross-linking areas decrease the crystallinity, and so you have a product that has low crystallinity, high cross-links, not too much free radicals. Okay? You starting to follow this? The other process is heat annealing. So you heat it up, warm it up, but you don't go above the remelt. So the crystalline areas don't come into a fluid form. So you keep your crystalline areas. So the mechanical properties are maintained. The crystalline areas tend to keep the free radicals. The higher heat does get rid of some of the radicals in the amorphous areas, but not many. But the cross-links are maintained. So putting it all together, if you got to be careful with a highly cross-linked polyethylene, increasing the cross-linking also diminishes the mechanical properties of polyethylene. So with high cross-linked polyethylene, you have a reduction of Young's modulus, a reduction of tensile strength, a reduction of fatigue strength, and a reduction of fracture toughness. And one of those will be on the boards. Remember that the reduction of Young's modulus and all those properties occurs when you remelt it. If you remelt it, then you get more cross-linking, you have less crystallinity, you change the mechanical properties. It's the crystalline areas that keep the fracture toughness, but if you decrease the crystallinity to increase the cross-linking, then you have a diminished mechanical properties. Okay? So a highly cross-linked polyethylene is not stronger, it's just more cross-linked, gives you better wear rates. Okay? Do you understand that? Highly cross-linked products are weaker overall, but wear better. So in a knee, where you have areas of contact stresses such as edge loading, you've got to be really careful with the high cross-linked polyethylene because you have a decreased fatigue crack resistance. Those reduce the margin of safety for fracture, and you could potentially get catastrophic failure with high cross-linked polyethylene if you have edge loading or an unbalanced knee. Here's another area that's a little bit more straightforward. Polyethylene shelf life. Irradiated polyethylene packaged in an oxygen-free environment minimizes oxidation. However, if that package over time degrades and you can get oxygen into that package, then you can get more oxidation, because when you irradiate a product or a polyethylene and you put it into a package, you still have some of the free radicals there. And if the oxygen trickles in through that packaging, you can get oxidation on the shelf. So depending on the packaging technique, the oxygen can diffuse into that polyethylene product. And the most critical factor is the packaging material and the O2 diffusion capability. So if you have a product that will diffuse oxygen in, you will have on-the-shelf oxidation, and you will have a product that's just as bad as gamma products in air. Remember that in terms of polyethylene shelf life, if the more oxidation you have, or the more you irradiate, the more oxidation you can have. So if you irradiate with high doses of radiation, you'll have more free radicals in that product stored. And if you allow that to oxidize on the shelf, you will have more oxidation occurring. So the worst case scenario is irradiated polyethylene stored in air sitting on the shelf for many years. The next worst case is a irradiated product stored in a vacuum packaging that leaks. But the test question is, irradiated polyethylene stored in air is going to oxidize on the shelf and can rapidly fail when you put that into the patient. So if you look at product failures, there's been a reported rapid failure of unit compartment knee replacements undergoing using products with gamma stored in air, meaning gamma radiated products stored in air with long shelf lives. The failure rates have been rapid. Similarly, Mirali Jasti has shown that when you have these jumbo-sized cups, the 72-millimeter cups that have been stored in air, that jumbo cup may sit on the shelf for 8 years, and you put that into a patient, it is so oxidized that ball will go in through like sliced butter. It'll wear so fast, it'll be awful. So remember, gamma in air is bad. So the lesson here is you want to avoid long storage times of radiated polyethylene, no more than 5 years. Be careful of odd lot sizes, as they could be packaged for as long as 4 to 7 years waiting to be used. Okay. Now going on to the hard. The problem with a hard on soft bearing couple is that cyclic motion of that articular head will always generate polyethylene debris because it's a hard on soft bearing. And no matter how you irradiate it or store it, it's still hard on soft and it's going to wear. So engineers and scientists have come up with hard on hard bearings. The bearing couples are metal-metal, which is cobalt chrome on cobalt chrome, or ceramic on ceramic. Okay. On a hard on hard bearing, the lubrication regime is mixed lubrication, meaning that with walking it's hydrodynamic. It's a fluid film lubrication, meaning that when that joint is in motion, there is a little bit of separation between those two surfaces. And at rest, when it's not moving, it becomes boundary lubrication again. Hydrodynamic lubrication requires motion of the joint. If the joint stops moving, then it becomes boundary lubrication. Therefore, on a hard-on-hard bearing, that's why it's called a mixed lubrication regime. So when you have a rough surface area such as metal and polyethylene, it is always boundary lubrication. But with these smooth hard-on-hard bearings, you can get hydrodynamic, i.e. fluid film lubrication. Okay. The bearing wear, if you look at a metal-metal bearing, the particles generated are much, much smaller than the submicron polyethylene beads. So the traditional thought is metal-metal bearings, they wear less. Well, they have less linear wear, exponentially less linear wear, but their particle generation is still even higher than polyethylene. And that's the part that you need to know for the boards. And they asked that in OIT 4, OITE 5, and will be on the boards, that a metal-metal bearing actually generates many more particles than polyethylene. However, the particles are so small, they tend not to elicit an osteolytic reaction with the activated macrophage. And that's been the reason for going to these metal-metal bearings. So they have very low linear wear, very low volumetric wear. However, the absolute number of particles generated is much greater than the polyethylene bearing couples because the particles are so much smaller. Okay. So the parameters for a successful hip bearing function on a hard-on-hard regimen, cobalt chrome on cobalt chrome or ceramic, is radial clearance, surface roughness, and sphericity. And radial clearance is one that they may hit you on. The radial clearance is needed for the optimum lubrication for debris removal. So if you don't allow any fluid to get into the system and you have no lubrication at all, then you're not going to get a good wear properties. So the radial clearance tends to provide egress and ingress of fluid for debris removal. The contact area generally is a polar contact high conformity, and that's defined by the radial clearance. So if you have a radial clearance that's very small, you're going to get equatorial contact and you're going to get fluid lockout, and that causes seizing and galling, and you get higher frictional torques and loosening. On the other hand, if you have a large radial clearance, you're going to have point loading and scratching and sliding wear, and that's not good. So the optimum radial clearance gives you polar contact with high conformity, and this is the general formula for radial clearance in a hard-on-hard bearing. Depending on the radius of diameter, you can define the radial clearance depending on the diameter of the socket in the ball, generally around 50 to 75 microns. They're not going to ask you the absolute number, but they want you to know the concept that radial clearance defines how the lubrication regime is going to be in the bearing itself. Surface roughnesses for these hard-on-hard bearings are very smooth. The roughness, as you can see with the metal and ceramics, are very, very smooth. Compared to machined polyethylene, the roughness is in the hundreds of microns, where a metal-metal bearing is 0.01 microns. In reference, a red cell diameter is 7 microns. So these are highly tooled, highly machined products. Sphericity, if you're out of round, you're going to get local stresses that can cause friction. So you want these perfectly round. Run and wear is a phenomenon that you need to know. It is on a hard-on-hard bearing. It's been seen with metal-metal. as well as ceramic. What happens is you put these two bearings together and you run them in for a while. It's just like your new car in the engine with the pistons. You get a high wear rate for the first million cycles, and then you settle down to this settle down to this equilibrium where you have lower wear steady state. So for that first million cycles, what you're really doing is polishing out the high points, and then you get this very low steady state wear. And that generally happens in the first million cycles, whether it's ceramic, or metal. It represents an in vivo polishing of the two round surfaces, and you are literally polishing out the high points. It represents basically a super polishing of the bearing, and what you're really doing is you're polishing out the carbide asperities, which are the high points. And also those areas out around are also being polished out as well. Okay. Debris formation, metal bearing. Remember, it's very small particles that are generated, and these metal particles can ionize to generate cobalt and chrome ions. So with metal bearings, you will see increased urine and blood levels of cobalt and chromium ions. The potential risk here is cancer. Remember that chrome has a high form and a low form, chrome 3, chrome 6. Cobalt chrome bearings are generally on the low level form. The theoretical risk is, does the body somehow activate the chrome to the higher oxidated states, causing cancer? The answer thus far is no. And if you look at the meta-analysis worldwide, there's been not associated increased risk of cancer. So for the board answers, there's no increased risk of cancer, but you will see increased levels of cobalt and chrome in the urine. The theoretical advantage for a hard-on-hard bearing is increased wear long-term, but the number of particles generated is still higher. And if you take those take-home points, you'll be fine. Okay. Remember, there's no cancer risk with ceramics because it's basically dirt. Ceramic heads, first generation alumina heads, there was a high fracture rate as much as 13.4%. This was due to poor manufacturing techniques, low density, and coarse microstructure. That's been all improved. So the third generation aluminas have a very low fracture rate. Generally, the process to get the low fracture rate is a hot isostatic pressed technique. So if you remember that. The reason for ceramic fractures is that you use skirted heads which impinge upon the acetabular cups. And this is just an example of a skirted head on an acetabular cup, demonstrating that if these were ceramic, it is the skirt that levers on the ceramic cup that causes a crack. Or if that is a ceramic head with a skirt on it, it will crack. So it's edge impingement that causes the failure on these ceramic femoral heads or cups. Okay. I've got actually a couple minutes. I've got to go to noon, so I'm going to grab all 10 minutes because I still got a lot to go. And I'll stop you. I'll stop promptly at noon. Okay. The next part is unstable total hip, and there's a lot of little pearls to look at for the boards here. The evaluation of the dislocated hip is often complex and usually multifactorial. Dislocation incidence up to 9.5% in primaries, typically 1 to 3%, and it's up to 26% with multiple revisions. I'll just move on to here. Typically, the revision rate, or the dislocation rate, dislocation rate in revisions is typically 5 to 7%. The highest incidence of dislocations is in patients over 80 with failed osteosynthesis of femoral neck fracture. So if you take your little old lady who is demented, you fix her head, it falls apart, you have this destructive lesion where the lag screw is cut out into the soft tissues, and then you put a total hip. Those are the patients that get the highest risk of dislocation. They're demented, soft tissues are damaged, they're not compliant, and the abductor complex has been compromised. So that's the highest dislocation incident. In terms of the assessment of the dislocated hip, you want to look at component design, component alignment, soft tissue tensioning, and soft tissue function. The primary arc range determines the extent of the stability. The factors affecting the primary arc are head size, neck thickness, and modifications to the cup and neck. And this will kind of congeal together here in these next couple slides. The primary arc range is greater with larger heads, and I'll show that to you in this in the next couple of slides. The taper design, small necks versus large necks, the primary arc range is greater with small necks. So putting this together, here's your diagram. You have a 180-degree cup, 22-millimeter head, standard taper. You take it through a range of motion, and you have an impingement on one side. You take the hip to the other side, and that's the other impingement. That arc is your arc range. So with a 22-millimeter head, typically your arc range is around 100 degrees. Okay? So if you increase the head size by going from 22 to 32, and you take it to the model, your range increases significantly from 100 to 120 degrees. Conversely, if you take your neck and narrow it down, and you still use a 22-millimeter head, and you use a narrow neck, you can increase your arc range to 122 degrees. And you'll say, well, how does that occur? And it has to go with the head-neck ratio. The head diameter to the neck diameter determines your primary arc range. So if you have a large head-neck ratio, then you are going to have more stability and have a higher arc range. So if you have a large ball and a narrow neck, you have the best of both worlds in terms of your range of motion. So increasing the head-neck ratio, if you use the same head size and use a smaller neck, as you see in this example, you increase your arc range. And here, same neck, which is a narrow neck, and you increase the head size, you can see here you also increase the arc range significantly. So head-neck ratio determines your primary arc range and determines your stability. That's what you're going to hear on the boards. Head-neck ratio. Optimizing head-neck ratio. Large ball, narrow necks, that allows you to go from point to point without impingement. So if you look at the head-neck modifications, any additions on the cup or the stem actually diminish the primary arc range. So in this case, if you have a primary arc range and you have, in this case, added a 20-degree posterior hood to prevent posterior dislocation, you've actually diminished your arc range. So even though you take it up the flexion and internal rotate, you won't dislocate posteriorly. Guess what's going to happen? You decrease your arc range and you lever out this way, you're going to come out the front because you're going to lever because you've diminished your arc range. Okay? Also, if you add a modification to the neck, you increase the neck with a skirt, you are going to change your head-neck ratio. So you have the same head, you add a skirt to it, you diminish your head-neck ratio, then you're going to have a less of a primary arc range. So here, you don't want to use skirted heads if you want to maximize your stability. And in addition, constrained liners, everybody thinks constrained liners are great, but actually they really diminish your arc range down to 60 degrees because you bring that polyethylene over the head, and then you can't bend. So if you have 60 degrees of arc range and your patient wants to go to 100, what's going to happen? One of two things are going to happen. The polyethylene is going to deform and you're going to dislocate out of the constrained liner, or that constrained liner, if it's not well fixed to the bone, you're going to knock that whole implant out. In fact, in Training 5 just showed this, a cage and a constrained liner, and it shows 3 months later this hip is dislocated with the liner. And the reason for the failure is the constrained liner because you've got this diminished arc range. So you've got to be very aware of constrained liners because they diminish your arc range, and if you don't have a compliant patient, you're going to bang that thing in every direction, and you're going to make it loose. So in terms of component design, collars for long necks decreases your primary arc range, and that's where you're going to get in trouble with dislocations because you're at the end of the limit. And that effectively increases your taper diameter. Acetabulate polyethylene liners, if you use augmented liners, you decrease your arc range. So you're stable in one direction, but you're going to be unstable in the other direction. And remember that constrained liners markedly decrease your arc range. Another part of the stability is excursion distance, and that provides additional stability. That's the lever out distance. It's the excursion distance to dislocate, and that's defined as the radius of the femoral head at impingement. And you say, what the hell is he talking about? So if you look here, if you have that same model, 22-millimeter head, and you lever it at the very end of its range, it's going to lever out. And the amount of distance it takes to lever out is the radius of the femoral head. So if you have a 22 millimeter head, it takes 11 millimeters to lever out, and boom, it's gone. Okay? So if you have a larger ball, you're going to have an increasing radius, and you're going to have a levering distance that's higher. So a 38 millimeter ball, for example, is going to have about a centimeter more levering distance to get out. That's why they tend to be more stable. So large balls are more stable for two reasons. One, because they have an optimal head-neck ratio, but also when they start to lever, it takes a lot to get it out. So a large head has a large excursion distance and is more stable. Whoops, excuse me. Went wrong direction there, my fault. And the most stable construct is a bipolar or monopolar arthroplasty. That's why we tend to use these large ball constructs in demented patients who are at risk for dislocation. Now going on to alignment. Let's see what I got for time. Yeah, I got a couple more minutes. If you look at component alignment, if we look on the acetabular side, there's acetabular version, acetabular tilt, and then there's femoral version. Remember that a malaligned component does not decrease the primary arc range. Rather, it doesn't correspond to the patient's functional range, and the result is an increased head excursions, and that means a higher risk of dislocation. Here's the example. You have here in the yellow the arc range of a normal hip, and then you put in the blue area the arc range of your total hip, whether it's a 28 head or whatever design you put in. But if you center the cup and the head in the middle of the patient's range, at the end of those range, you're going to start to have levering or excursion. And then you're going to, at the very end, where that green dot is, then you're going to lever out. So if you center your components exactly, you'll be in the middle of the range. If you go too much, you'll get a little bit of excursion, but a little bit of levering, but it won't come completely out until you go way out to the very ends. However, if you don't put those parts in centered in the patient's functional range, you still have the same arc range, so that on the stable side, you're going to be completely stable, but on the other side, if it's you start to lever, you're going to come way out of socket. So if you have a retroverted cup, for example, and you just flex up to 90 degrees, you're going to start to lever, and then you go a little bit more, you're going to come out of socket. So the malaligned component has normal arc range, but you just got to center it in the patient's functional range. Hence, that's why we come up with component alignment. Acetabular version needs to be between 20 and 30 degrees to center it in the patient's arc range. So in this case, this is a left hip. Cup anteversion is too high. Here, the anteversion is probably about, what would you say, about 60 degrees. And so when you come in extension, you're going to come out the front. So here's the anteversion corrected down towards 30 degrees. Similarly, if you have a retroverted cup, you're going to flex up and you're going to come out the back. So a retroverted cup is going to impinge, and you're going to run the risk of posterior dislocation. So anteverted cups, anterior dislocation; retroverted cups, posterior dislocation. Remember that concept. Theta angle is important. You want a theta angle in the coronal plane of about 35 to 40 degrees. Low theta angles with abduction will impinge, and you can come out of socket. High theta angles also run the risk of a superior dislocation. So you have a theta angle that's vertical, you're going to come right out the top. Femoral stem version needs to be around 10 to 15 degrees for normal anatomy. They typically should line up along the same axis of the femoral neck. Here's a case where your anteversion is incorrect. Here you run the risk. This is a retroverted stem on the right, and you run the risk of dislocation, and your anteversion tends to follow the native femoral neck. So if you have a retroverted stem, you run the risk of a posterior dislocation, as it tends to impinge earlier in flexion. So a retroverted cup is posterior dislocation. A retroverted stem runs the risk of posterior dislocation. Okay. And it's important with intraoperative trialing to take the hip through the extremes of motion and anticipated rotation. So you want to take that hip through the patient's functional range. You know, the patients just don't go to 90 degrees. You want to take it all the way up to 100. If it starts to lever, that's okay, because you're just testing the excursion distance. So you want to take it up to 100. You want to take it into full extension, and then you want to rotate it and see. So remember, it's putting the parts in the middle of the patient's functional range. Remember also, positioning is great, but it's the muscles that keep the hip in place. The abductor complex is the key to stability, and the abductor complex includes the gluteus medius and the minimus. And to recreate that tension, you've got to have good preoperative templating where you measure head offset and measure neck length. And what you do with your hip replacement is what you want to do is restore the head offset and restore the neck length. And you have templating, and in this case here, you're templating to find the center of rotation, and then you define your neck cut and put the implant at that level so you can recreate the standard offset and the length, because that's what keeps your hips stable. So you template properly, you put your implant in properly, and what you have in the final goal is restoration of abductor tension. So if you have the appropriate measured offset and length, you will have a reestablishment of the normal hip center, you will have a restored offset and a restored neck length, and that gives you your abductor tension. That's why we template. Sure, you can template, and if you don't template and you cut low all the time, a couple of those hips, your abductor complex is going to be narrow, and you're going to be able to loosen, and you're going to dislocate. So we really want to restore center of rotation, offset, and neck length. Those are the keys for stability. So with restored hip mechanics, you have normal abductor power, hip compression, and hip stability. Conversion of a hip fusion to a total hip. The predictive factor for improved walking is adequate abductor function. I throw this in because this goes in with abductor functioning. So if you have a hip fusion and you want to restore and convert it to a total hip, if your abductors don't work, then you're going to have a limp and you're going to run the risk of a recurrent dislocation. And the way you test that preoperatively is with EMG testing to see if your abductor complex has been deinnervated. If your abductor complex has been cut neurologically and is not working, then it's not worth the conversion. Okay. Shorten tension, soft tissue tension. If you shorten your hip length and you make it short with a low neck cut, you have a weakened abductor complex. The soft tissues will cause a trochanteric impingement, and you will have instability. So in this case, you don't template. You just do, I just make a finger net. I just cut a finger breadth above the lesser troch. A couple cases, you'll have a shortened hip length, a diminished offset, and you'll have a weak abductor complex, and then you run the risk for recurrent dislocation. And if you use a low neck cut and you use a short head, then you're going to get secondary impingement with troch levering, and you're going to dislocate, and that's even the worst problem. So, and here's one of my cases that I chose the wrong implant. I used a narrow offset high neck shaft cup or a stem and a low theta angle cup, and I had troch impingement and had recurrent instability in that case. Now, you'll say, well, I'm going to trial it. I'll just do a finger breadth cut low. Okay, I'm a little short. I will just use a longer head. What's the problem with going with a longer head? You have to use a skirt. And if you use a skirt, then you run the risk of decreasing your head-neck ratio, and there's where you run your risk of dislocation again. And it all goes back to normal offset, normal neck length, restoration of center of rotation. So that's the problem. Also, I've seen this as well, is that if you cut short and put on a long ball and you push out too far, you increase your offset to get your length back, then you have trochanteric bursitis. And the reason you get that problem is that your neck shaft angle of your prosthesis is lower than the native neck shaft. So if you have a varus neck shaft angle relative to the patient's native implant, you'll push it out this way, and then you'll get the bursitis. Each implant has a neck shaft angle that's different. Some are 135, some are 128, some are 132. It just depends on the implant design. But you've got to know these little nuances. You can avoid all this by proper preoperative templating, offset, neck length, center of rotation. I'll go through this and then I'll stop. Soft tissue tensioning. Trochanteric escape is a tough problem because the trochanter has the abductor complex. You have an increased functional hip range as the trochanter no longer restricts the hip. So you take your trochanter off, it no longer is in the way. So when you're trochanteric deficient, you can turn all the way out, turn all the way in, then you lever, and then you dislocate. Plus, you don't have that compressive hip stress. And that's a big problem. So if you have a trochanteric escape, that's a tough problem. You lose that hip compression, run the risk of instability. The solutions is debride the trochanter so it doesn't impinge at all with any of the scar tissue. You optimize the head-neck ratio so you use a larger ball and a narrower neck. That may come at a price with a thinner polyethylene for higher wear, but I'd rather have the stability. You have to change to a hemisphere cup, no hoods, so you want to maximize that arc range as much as possible to maintain your stability. So here's a case of trochanteric escape. I debrided that area and it dislocated even with the debridement, and that was revised to constrained minor. So with that, I'll stop right there and let you guys have lunch break.